Thank you. Can you hear me all? Thanks. Great. Yes, I have a lot to say, and to give an overview of fluid physiology is certainly a challenge, but I'll still take some time to tell you a little story. This is my hospital from an idealized point of view, and I work at the back. This is my office up here. If I put myself here and turn around 180 degrees and look down, I pass this area every day on my way to work. This is a cholera graveyard from the 1850s. In those days, there was no hospital here. It was a countryside, and people were buried in a mass grave here, just outside the city and far away from the church, and no sacred soil here. So that tells me that a lot of things has happened in our knowledge about how to manage fluid therapy. Reminds me that every day. And of course, if people have problems with their fluid balance, we need to help them. And there are several groups of people who need intravenous fluid therapy just because they cannot handle this by themselves. And what are the main principles? We can say that the minimum requirement of fluid in adults is 1 milliliter per kilo per hour, and sodium and potassium also 1 millimole. So the 1-1-1 rule is quite easy to remember. And of course, this is to compensate for evaporation from the airways and also from basic fluid excretion by the kidneys. Now, if somebody cannot drink and eat by themselves, the mainstay of fluid therapy is a glucose solution, usually 5%, and that is because we call it maintenance because it just replaces what is continued to lost by baseline urine excretion and evaporation. One must just remember here that some electrolytes have to be added, at least if you prescribe more than 1 liter of this fluid, because otherwise there's a risk of hyponatremia developing. Now, this amount of glucose is not very large at all. 1 liter contains 200 kilocalories, and so this is an undernutrition. Actually, it's a little less than would be required to prevent starvation. So after a couple of days, we must rethink and compensate the requirements for nutrition more ambitiously. And that is nutrition. That's another area of our specialty, really. But you can begin with 5% glucose solution. So you may wonder, why don't we give more of the glucose? We don't do that because some phenomena are around here. First, the man's capacity to handle glucose is much poorer if you give it intravenously than if you give it by mouth, because we trespass the gastrointestinal hormones that help the insulin to work. And also, patients in trauma have developed something we call insulin resistance. It means that the insulin doesn't have as good effect as it has in an adult who is healthy. I have made this graph to explain a little more, or to illustrate the power of this insulin resistance. So you can see here that the amount of glucose that can be given to a person who is in the perioperative setting or who is severely ill, it has to be much less given until you reach these isobars of plasma glucose. So you more easily get into hyperglycemic situation where you have an increased risk of infection, and of course if you go even higher you have osmotic diuresis from the kidneys, which is not very good at all for the body. Okay, we'll leave that topic and we'll take a look at the basic principles of composing an infusion fluid. We have 3 main body compartments with fluid in the body, and there are 2 membranes that separate these ones. First, we have the capillary membrane, and here we can change the composition and the concentration of macromolecules. That, if you don't have any macromolecules, fluid easily go in this direction. If we contain the fluid, if we have a fluid content with macromolecules, we work to save it here in the plasma. Here, we can change the flow of fluid here by manipulating the amount of electrolytes. So that is very important to remember, that we can really, by tailoring our fluid, make the infused volume end up anywhere here, or we can change, we can borrow fluid from this space to this space by just providing a fluid with a concentration of electrolytes that's very high. Okay, so if we want to have the fluid to stay in the extracellular fluid compartment, which we often want, because this is what we need to do if we have hemorrhage, if we have a severely sick patient, we need to have a plasma volume expansion to maintain normal hemodynamics. We have many fluids here to choose from, and the main types, of course, are the crystalloids and the colloids, and there's a lot to say about this. But we need to take a look at how they behave in the body. If we infuse crystalloid electrolyte solutions intravenously over 30 minutes, if we give 2 liters here in volunteers, we'll have a pretty good plasma volume expansion to begin with. During infusion, we have around 50% of the fluid remaining in the plasma, and over the subsequent 30 minutes we have a distribution of this fluid from the plasma to the interstitial fluid space, and that requires about 30 minutes to be completed. So after at 1 hour here, we have a plasma volume expansion that's around 20% of the infused amount. But during infusion, over 30 minutes after, we have much better. So this is the elimination phase. This is the distribution phase. And we know that the saline has a longer half-life in the body, so the kidneys have some difficulty to excrete that. Okay, if we take a look at the colloids, they have a mono-exponential elimination course, and you see that the duration is quite long, so about 6 to 8 hours we have to count on in that setting. If we compare the two, we'll find that if we infuse it like a bolus here over 15 minutes, we'll have about twice as large plasma volume expansion from the Voliven than from the ringers. If you say we compare here 1 liter of ringers with 500 milliliters of Voliven, they compare about the same, but the distribution phase makes this difference increase. And okay, the difference between the two types of fluid over time is quite time dependent, as you can see from that graph. Of course, we have control systems in the body that sort of modulates the effect of the fluids. We can in particular, in anesthesia, we have a sympathetic tonus is lost. That's very important. And also the hormonal systems come into play. There's a lot of experimental data on this, of course, but it's difficult to say during major surgery which factor is more important than the other. But of course, you know the vasopressin saves fluid in the body, retains fluid. This produces excretion and capillary leakage of albumin, cortisol, and renin-angiotensin, or retains fluid in the body. I just want to show here the effect of anesthesia as such on the renin-angiotensin system. These are experimental anesthesia, so there's no surgery being performed. But as soon as volunteers are being put under general anesthesia, we'll have an underperfusion of the kidneys with an increase in the plasma aldosterone and renin concentrations, while we have no intrinsic effect of vasopressin by inducing isoflurane anesthesia, which was in this case a quite light anesthesia. Also, by the way, but it's interesting to see that these factors come into play. But the relative importance of this is a little difficult to elucidate. It's important during general anesthesia. We found that the half-life, the rate of elimination of crystalloids, is very, very slow. And it's shown by this graph here that if we infuse crystalloids in volunteers, we'll have about half of it excreted within 1 hour. So we give it over 30 minutes. But during general anesthesia, that is very much more slow, so only 10% something. Is that due to the hormonal cascades? Probably not. It's more related to arterial pressure, which is always lowered, age, and adrenergic status of the patient. This is a graph showing the effect of mean arterial pressure of the excretion of 1 liter of Ringer's acetate given over 30 minutes. So it's very dependent on arterial pressure. Okay, we should know that if you provide fluid, it always affects the hemoglobin concentration. So these 3 parameters are associated with each other in mathematical relationships. The most dangerous one, if you have a hemorrhage here and you have no decrease in hemoglobin concentration, a very small one, then you have a hypovolemic status. So it's important to remember that these should always match if you have normal volemia. We'll say a few final words about the rules of fluid administration during surgery. We have 3 approaches. Fluid balance, you just calculate plus minus. Outcome-oriented approach, that's for groups. It's been around for about 15 years, where researchers have randomized patient groups to different fluid programs, and they found that this program is better than this, and then we can come with a recommendation. Goal-directed fluid therapy is something different. It's, again, an individualized approach. We have a review here showing that 2 milliliter per kilo per hour during surgery is really too little. I said that the basic fluid administration should be 1 milliliter per kilo hour, but now we seem to be necessary to increase the amount. And actually, if we come up to 3 milliliter per kilo per hour, we don't have any increased incidence of nausea and vomiting postoperatively. And the reason for this is that anesthesia always induces some kind of adrenergic imbalance. We actually get a mild form of distributive shock. So blood flows are being redirected in the body and redirected away from the gastrointestinal tract, so on. So we must have some degree of hypovolemia in this setting. Now, if we give more fluid, what happens? We have studies saying that problems from the capillary leakage of the crystalloid fluid cause problems in increasing number, looking like this. And if you increase it even more, up to 7-8 liters, we have a split up of tissues because we now change the we change the normally negative interstitial pressure into positive, and then we have, this is an animal heart where we have myocardial fibrils here, and we just water here. So tissue break up, and we have organ dysfunction, of course, as a result of that. So there are problems with fluid overloading that has with split up of tissues to do. Also other issues with edema that we will hear more about later today. We just summarize the ideas of colloids. Now, colloids have been a little out of practice, I would say, the past years due to the reports of kidney injury from the use of hydroxyethyl starch. But of course, it gives a pronounced and stable plastic volume expansion, and if you want that, this is the fluid of choice. So if we want to use goal-directed fluid therapy, that is something that is very commonly used. Yeah, hydroxyethyl starch is beginning to be out of practice, perhaps. There are two randomized studies going on at this time, and we will see the results soon. Finally, glycocalyx, I don't have time to talk into detail about this, but it's around, and it may shorten the intravascular persistence of colloid fluids. I've done studies on this, and we haven't seen that much of increased capillary leakage so far. But conclusions, yes, minimal fluid requirement, you see 1 milliliter per kilo per hour. Maintenance is 5% glucose with solutions, and this is the mainstay during surgery. And turnover of crystalloids is very slow during surgery. So thank you.